Hello and welcome to our July-August CMF Podcast. I'm Professor George Bakris, Professor of Medicine and Director of the American Society of Hypertension's Comprehensive Hypertension Center at the University of Chicago Medicine. The CMF is a free educational resource for clinicians, and this podcast aims to update you on some of the latest publications in the field of cardiometabolic diseases and implications for clinical practice. Today, I'm joined by Professor Richard Donnelly, Emeritus Professor of Medicine and Editor-in-Chief at the University of Nottingham, United Kingdom. Hello.
Hello. I'm very pleased to join you today, George, to discuss the main findings from three key publications that we've selected out of the monthly literature search in July and August, and hopefully try and distill the most relevant information for everyday clinical practice.
So the first paper is by Petoulias et al., The Effect of Semaglutide versus Other Glucagon-like Peptide-1 Receptor Agonists on Cardiometabolic Risk Factors in Patients with Type 2 Diabetes, a systematic review and meta-analysis of head-to-head phase 3 randomized controlled trials. So the introduction to the paper is that we're going to discuss this in the context of what the study summary is. And basically what the authors did is they looked at PubMed and Cochrane databases for head-to-head phase 3 randomized controlled trials, assessing the effect of semaglutide versus other GLP-1 RAs on glycemia and other cardiometabolic risk factors in subjects with type 2 diabetes. This reviewed analysis of 5 trials, which is ultimately what they found, collectively, that's 3,760 patients that they looked at. Semaglutide, compared to other GLP-1 RAs, provided a significantly greater reduction in hemoglobin A1C levels by 0.44%, in fasting plasma glucose by 0.48 millimoles per liter, and body weight by 2.53 kilograms, and body mass index by 0.91 kilograms per meter squared. Subjects receiving semaglutide experienced significantly greater odds of achieving the target and optimal hemoglobin A1C, along with significantly greater odds for weight loss of greater than 5 and 10%. However, subjects randomized to semaglutide also experienced significantly greater odds for gastrointestinal adverse events and treatment discontinuation. Investigators concluded that compared to other GLP-1 RAs, semaglutide provided a significantly greater reduction in hemoglobin A1C, fasting plasma glucose, body weight, BMI, waist circumference, blood pressure, and triglycerides. However, treatment with semaglutide was also associated with significantly greater odds for GI adverse events and treatment discontinuation. So, Richard, what are your thoughts?
It's an interesting meta-analysis, isn't it? I mean, 5 trials, but I guess those trials were all quite different in terms of doses, perhaps duration of therapy. And I'm also curious, George, whether the GLP-1 agonist was being used simply as add-on to metformin in all of the trials, or whether in one trial it was add-on to metformin, in other trials the GLP-1 might have been used as add-on to dual or triple therapy. Do you recall some of the detail of those 5 trials?
Yeah, I don't recall all the details, but I do recall that what you're saying is true, that basically these are people that were on therapies. They were not ideally controlled, and they needed something else. So they were testing this versus other drugs or placebo. And these findings are what they got, which is, I think, representative of what I see in clinical practice, at least when this is used. And a lot of these side effects that we're talking about, the GI side effects, are dose dependent. And some people we can get people up to 2 milligrams and there's no problem at all. Others, they're down at 0.6 and they've got nausea, they can't go any higher. So it is almost individual patient based. And you can't, obviously, with this, you have to start low and go slow. Otherwise, you will have 100% GI side effects. But I think it's important for the listener to know this.
Yeah. So I guess the takeaway message for clinicians is that semaglutide is probably more potent on all of those cardiometabolic risk factors, but the potential price that you pay for that potency is potentially an increase in risk of nausea and some upper GI, mainly upper GI side effects, and patients not persisting with therapy. Is that right?
That is 100% correct. And the other point related to this is that not only if you discontinue the drug, not only do you lose the metabolic benefits, but if there was any weight loss, you've gained the weight back. So I think that's something that a lot of people don't appreciate it. They think that this is, especially in the higher doses, a panacea for weight loss. And as long as you're on it, it is. When you stop it, it comes back. So I think that needs to be known.
Yeah. Maybe I could just one last comment on that study, George. Can I ask you what you thought about the blood pressure and heart rate data and whether there was anything there that surprised you?
No, it's pretty consistent with other things that have been found. The interesting thing with these drugs are they don't reduce heart rate. In fact, they may increase heart rate a little bit. Nobody really understands specifics of why this is. It certainly hasn't been found to be a problem, but I think one has to be aware in someone that may have pre-existing resting heart rates that are very high. This could be something that could be a consequence, but in general, I haven't found it to be any problem. And you will get some blood pressure lowering, and that's reflective of weight loss. So as you lose more weight, blood pressure will drop more. It's as simple as that.
Yeah, great. Well, we should probably move on, and I think I'm going to present the second publication, which is quite an exciting publication, which appeared in The Lancet. It's authored by an impressive lineup of authors led by Philip Knopp. And this was a randomized, double-blind, placebo-controlled trial of an oral formulation of semaglutide in a dose of 50 milligrams in patients with overweight and obesity who do not have type 2 diabetes. Obviously, the background to this study is that GLP-1s have largely been injectable drugs, and the whole process of an injection is quite a barrier for many patients and has limited the patient acceptability and the willingness to use GLP therapy. So this is a new formulation of oral semaglutide administered once daily in a much higher dose than the doses that are currently licensed in patients with type 2 diabetes. So it was a double-blind, randomized, placebo-controlled phase 3 trial. These patients all had body mass indexes above 30 or greater than 27 in combination with a comorbidity such as hypertension or dyslipidemia. And they were all receiving lifestyle advice and standard non-pharmacologic therapy. And they were randomized double-blind to oral semaglutide or placebo over a period of 68 weeks. The co-primary endpoints were changes from baseline in the percentage change in body weight and the proportion of patients who achieved more than 5% or 10% reduction in body weight. So the baseline, there were 667 randomized patients. They didn't have type 2 diabetes. 3/4 of them almost were female, average age of 50, And you can see there that their mean body weight was 105 kilograms, and about a third of them had a BMI above 30, a third of them had a BMI above 35, and about 30% of them had a BMI over 40. So I guess a pretty typical population of patients with obesity, although perhaps a bit of gender balance. There was a strong preponderance of females randomized in the trial. And this slide really shows pretty impressive results. It looks at the change in body weight from baseline over the 68 weeks. And you can see that the estimated treatment difference was minus 12.7% in body weight loss in favor of those patients who were taking oral semaglutide. So pretty impressive. This is an oral formulation, which obviously is going to be much more acceptable to patients. And the placebo group, I guess, had a very small reduction in body weight. And the semaglutide treated patients had a very significant reduction, which appears to be bottoming out as you get to 60 and 68 weeks on that graph. And this shows the other primary endpoint, looking at the proportion of patients who achieved 5%, 10%, 15%, and even 20% reduction in body weight. And you can see the columns in blue or purple are the oral semaglutide group. And so almost all of them, 85%, achieved 5% body weight loss. 70% achieved 10% body weight loss, and half of them, more than half of them, achieved 15% body weight loss, which is really substantial for a trial that's running for just over a year. And then the final column, which I find quite amazing, that a third of these patients randomized to semaglutide achieved more than 20% in weight loss. I mean, that's significant weight loss in a population with baseline body weight of over 100 kilograms. And I think on the next slide, there's a summary of some of the adverse events with oral semaglutide. And what occurs to me was that the gastrointestinal adverse events, which we're very familiar with injectable GLP-1s, don't seem to be quite as much of a problem with the oral formulation. There were GI adverse effects reported in 46% of placebo-treated patients and 80% of oral semaglutide patients, but nevertheless, that difference isn't as large as we might expect if we were looking at a randomized trial of an injectable GLP-1. And at the bottom there, the number of patients persisting with therapy was really very good. So only 6% of the semaglutide patients dropped out. I guess because they quickly realized that they were losing weight. The weight loss graph started to separate very early on. And so patients persisted with therapy much better than they might have done with an injectable agent. So I think these results are really quite exciting. It's using a once daily oral formulation of semaglutide in a new dose of 50 milligrams. And it's the first oral GLP-1 agonist to be investigated for the treatment of obesity in adults who are overweight or obese. The semaglutide formulation induced substantial and certainly clinically meaningful reductions in body weight, and they were accompanied by improvements in cardiometabolic risk factors, all relative to placebo in a double-blind design. And the safety profile seems encouraging. and the dropout rate was really very low, I guess reinforcing the fact that the oral formulation is probably going to be more acceptable to patients. And when patients already experience weight loss quite early on, they're more inclined to persevere with therapy, even if they do get a little bit of gastrointestinal upset. Any thoughts on that, George?
Well, it's a very nice paper, but I think the listeners need to be aware, in the States, we have this, it's being used by a number of clinicians, and I've seen patients for other reasons referred to me who were on the oral medication, and I've realized that they hadn't lost any weight. And really, their metabolic profile hadn't improved very much. And I was trying to figure out why that could be. And I think the listener has to be very, very cautious when they're giving these drugs, because it makes it sound like it's another pill. You just take it. No, there's a very specific process that you have to follow when you take these medications. And if you don't, you might as well throw it in the toilet, because that's where it's going. You need to really be persnickety, not you, the physician, but you need to tell the patient that if the pill is going to work, it needs to be taken in a very specific way and what that is. And if you don't follow that, it will not work. The patient that I'm talking about was educated on this, and we saw them back in 3 months. And now guess what? They had lost the weight and they had some nausea. So they were taking it properly, and they never were told that in the first place. So this is very important. I think the interesting thing about the oral preparation is, in fact, as you pointed out, Richard, it's got less GI side effects. It still has GI side effects, but less GI side effects than the injectable. And I'm not really sure I understand why that is, but it is.
Yeah, it's interesting. You might intuitively think that if you're taking it orally, it might have more localized nauseating effect, and in a much higher dose than the dosages that are licensed in type 2 diabetes. So yeah, maybe the adverse event profile is pleasantly surprising.
Yeah, I think that is the take-home message, because the at least in the States, this medication has taken off, along with some others that are specific for weight loss, but also involving the GLP-1RA access. And they're people are paying out of pocket. They don't care. They want it. The problem with all of these agents, yes, they're amazing. Yes, they've got a great profile. Yes, they improve your cardiometabolic profile. No questions asked. People have come off blood pressure medicines. People have reduced their statin medications because they've lost the weight. Sleep apnea has gone away. Very impressive. Oh, by the way, you're addicted, because if you stop this, you will gain all of that weight back and then some. So I think that's the caveat here that you need to understand. This is not the magic pill. So I'm just putting that out there in case somebody thinks it is.
Yeah, it needs to be used in conjunction with lifestyle modification, activity, and hopefully patients might get to a point that they've sufficiently changed their eating and their activity patterns that they can maintain the weight loss without ongoing medication.
Right. This is exactly what you said, Richard. When I give these medicines out to patients, I make this very clear, and I make sure they understand not just the dietary aspect of this, but exercise and proper sleep and all of the lifestyle things. And if they don't do that, they're going to be addicted to this for life. So I hope they have enough money to pay for it until they're done. I mean, that's really the bottom line.
Yeah. Well, it's early stage, I guess, but that's a phase 3 trial, I guess, for the purposes of regulatory approval. And
Yep.
who knows? We do know that patients in phase 3 trials are not necessarily representative of routine clinical practice.
That's true.
But it's a step forward in terms of us having another option to use.
No question about it. No question about it. All right. Well, let's move on to the third presentation by Bika et al. On the effects of SGLT2 inhibitors on steatosis and fibrosis in patients with non-alcoholic fatty liver disease or steatohepatitis and type 2 diabetes. This is a systematic review of randomized controlled trials. And I think it's important to keep in mind here that this study looks at a very important condition that has been, up until recently, largely underappreciated, except by our friends in GI. And the endocrinologists now are paying a lot of attention to this. And in fact, there's cooperative studies that are being done. So this is type 2 diabetes and NAFLD. They're part of the metabolic syndrome and share multiple causal associations. And there has been an alarming increase of obesity, but also NAFLD because people are looking for it more. And this does have impact on other organ systems as well. And it also has an impact on cardiovascular risk. So SGLT2 inhibitors have been identified, as you know, as an anti-diabetic class of drugs with well-established cardiovascular benefits. But I want to make a point that these drugs, the SGLT2 inhibitors, independent of anything to do with glucose control, provide kidney and cardiovascular benefits down to a GFR of 20. And guess what? You get no glucose benefit at GFRs below 50. So these drugs are doing multiple other things. It's not just an osmotic diuretic from glucose. So this is important. So this study obviously did the proper analysis. They went to Medline, Cochrane databases, and they looked for randomized trials of SGLT2s in this disease condition. And they originally identified, now this shows you what proper sieving does, 179 articles, 21 of which met the data analysis criteria. All three SGLT2s were used were evaluated in this context. And no, the issue is when you are, looking at the data, there's a large amount of variability in the sample size and endpoint study. So again, there's nothing really consistent about this because of different studies and different inclusion criteria. But the bottom line is that SGLT2 treatment definitely improved non-invasive markers of NAFLD and NASH. And obviously further trials are necessary. Everybody likes to say this. Further trials are necessary. These are not definitive, but this definitely sends you a consistent signal of benefit in alleviating the situation. And I think that's important. So I think the point is that first of all, you need to screen for NAFLD. And the screening test includes platelet count, which is interesting. But the point is, if that's positive, then you should look for this and see if you can improve it. Now you can say, well, I'm giving SGLT2s anyway, who cares? It's going to get better. But you don't know, and you really do need to follow this because cirrhosis is a consequence of this in a minority, but nevertheless it is. So you do need to pay attention. Richard, what are your thoughts?
Yeah, I'm curious about what the non-invasive markers were that they used in these different trials, George. And were they all using FibroScan, or were they using a combination of other biomarkers, for example, to measure steatosis?
Well, that's a good question. My recollection is that they did use FibroScan. That's kind of a standard. I think it's called the FLIT1 test or something where you take different lab values and put them together and end up with the score. And really, I don't think there's anything beyond that has been accepted as marker.
Yeah. I know in a UK perspective, NICE have recently endorsed this sort of use of fibroscanning in primary care. And I think there's a huge educational need for primary care physicians to be able to understand what they should do next when they notice abnormal liver function tests on patients with diabetes or just obesity. And I think there are moves to try and get fibroscanning adopted and applied in a primary care setting, perhaps to try and, as you say, select out those very high risk patients who are probably going to go on and get cirrhosis and all the nasty complications that come with it. But it is a very interesting area that's adding to the breadth of what SGLT2 inhibitors do. If the heart and the kidneys wasn't enough, we now have, the other major organ in the abdomen, the liver, and there is a huge amount of NASH around when you look.
Yeah, that's the thing. It's been around, and it's around more now because you're looking, so you're finding it. It's as simple as that.
Yeah.
Right, very good. Well, listen, we hope you've enjoyed the discussion in this podcast and find it useful and informative, and hope we gave you some tips that may help you in clinical practice. For slide summaries on further publications, head over to CMF at Cardiometabolic.com. All the resources are free to download for your own updates, teaching, journal clubs, and more. To stay up to date with new updates, join our mailing list and follow us on social media to find out when more slides, literature highlights, and podcasts can go live. Thank you for joining us, and please visit CMF to view podcasts by other members of the CMF Steering Committee. Thank you, Richard. And
Great. Thanks, George. That was an enjoyable discussion.
Thank you.